Prasad, and as you know, we are recording series of lectures for pharmacists who are going to appear for international equivalency exam. And new viewers are requested to go and watch our previous video so that you can get about our preparation plans. So let's resume our topic, that is the remaining part of antidepressants. And point number one is about the monoamine oxidase inhibitor, that a drug, its name is glutathiamidine. It is actually an inducer of monoamine oxidase inhibitor, and you can easily understand what inducer do work. It actually enhance the effect of our drug. So glutathiamidine is an inducer of monoamine oxidase inhibitor. Point number two is about the fluoxetine. It's a selective serotonin reuptake inhibitor. Its dose is about 20 to 60 mg per day, and it don't cause hepatotoxicity. As other drugs of same class, whose name is sertraline, whose dose was almost 50 to 200 mg per day, it causes hepatotoxicity. So once the patient has a problem of liver side by side, you need to SSRI, then fluoxetine is one of the best option. Point number three is about the amitriptyline. Amitriptyline, as we told you in previous video, that the effect of tricyclic antidepressant appears after 3 to 4 weeks because of the activation of autoreceptors. So it is also discussed here in this point that its effect is very sleepy and very dry mouth because of anticholinergic effect, and no progression in depression, exactly because it causes its initial effect of antidepressant as an antidepressant after 3 to 4 weeks. Point number four is about a drug, that is the dipoxipine. Its dose is 150 to 300 mg. It's actually tricyclic antidepressants. Point number five is about the clomipramine. Clomipramine is also tricyclic antidepressants. Its dose is from 100 mg to 250 mg per day, and it is actually used for the occlusive depressions. Point number six is about an contraindication between amitriptyline, and as you know, its dose is 100 to 150 to 300 mg per day, with the diuretics, that is the chlorothiazides. Its dose is the chlorothiazide dose is from zero point 0.5 to 2 gram per 2 gram. It is given in the 2 times per day. So when chlorothiazide is given side by side and side by side the amitriptyline, then it can cause additive effect in blood pressure lowering. So both of them in a single combination is contraindicated. Point number seven is about just a basic principle that you must need to know about all the drugs. Almost all the drugs of all the classification should be at your fingertip. It can be asked in exam. Just like, for example, there's a drug that its name is carbamazepine. They can ask what is its drug class. That is it's an anticonvulsant. Similarly, trazodone, as you know, its dose is 150 to 300 mg per day, and it's an antidepressant 5-HT receptor modulator. Similarly, molindone, it's an antipsychotic drugs. Similarly, alprazolam, as we talk about in a GABA previous chapter of sedative and hypnotics, it's an GABA. It's works through GABA receptors, and its dose is 1 to 2 mg, and it's an anti-anxiety drug. Next is the isocarboxazide. Its dose is 30 to 60 mg per day, and it's an monoamine oxidase inhibitor, example of monoamine oxidase inhibitor. Similarly, amiloride is a potassium sparing diuretics, and cemestine is an antihistamine drug, and diltiazem is a calcium channel blocker, and sulfamide pyrazone, sulfamapyrazone is an uricosuric agent. So in this way, they can ask about they can mention the drug class, and they give you some examples that choose which drug belongs to this class. Or sometimes they can ask like this, that they will give you a drug and question with you about which class this drug, which class this drug belongs. So you just need to have a grip over drug classification. Point number eight is about the bipolar disorder. As you know, it's a manic phase as well as depressive phase. So here point is that about its treatment plan. As I told you earlier, that it's lithium, carbamazepine, valproic acid, two anticonvulsants, and Side by side, SSRI, selective serotonin receptor inhibitors, and haloperidol. These are among its treatment plan. As you know that, but I think so. Remaining few drugs know that carbamazepine and valproic acid is anticonvulsants, and SSRI is selective serotonin reuptake inhibitors. The example is about citalopram, paroxetine, fluvoxetine, and sertraline. But haloperidol is a new, which we are discussing it first time. It's actually a post. It's actually a antipsychotic drug, and it actually block D2 receptor at postsynaptic membranes. So point number 9 is about some classification, like it's a drug like bicyclic antidepressant drug. Its example is viloxine, and tricyclic antidepressants. As its examples are amitriptyline, clomipramine, and decimipramine, depoximine, and imipramine, and nortriptyline, and protriptyline, and trimipramine, and similarly tricyclic and unicyclic antidepressants, like example are amoxicillin and bupropion, and mirtazapine and meprotilene. These are the example of these drugs. And as long as the doses are concerned, just let me for the record, I will like to mention here its doses. I will let you know about a very simple recall point that you can say imipramine, like all the means, imipramines, trimipramine, and desmipramine, and depoximine, and amitriptyline. These five drugs have a same dose range, right, for around 150 mg to 300 mg per day. Other remaining is clomipramine, its dose is 100 to 200 to 50 mg, and nortriptyline, its dose is 50 to 150 mg, and protriptyline, its dose is 15 to 60 mg per day. Similarly, tricyclic, unicyclic antidepressants, it's actually amoxicillin. Its dose is 150 to 400 mg, and bupropion, its dose is 200 to 450 mg, and mirtazapine, its dose is 15 to 45 mg, and meprotilene, its dose is 150 to 225 mg. So this is just for record that these are the example of tricyclic antidepressants, and these are the its dose ranges. Side by side, there are serine and meprolitine. Exactly, menserine is a new drug which is I forget to tell you in previous list. So these are the example of tricyclic antidepressant drugs which you must need to know in, which you just need to recall in your mind, because question can be among them. So point number 10 is about the aspirin and MAOI. Aspirin doesn't interact with the monoamine oxidase inhibitor, so you can use aspirin with in those patients who are using monoamine oxidase inhibitor drugs. Point number 11 is about, again, antidepressants. It's just about the reminder that you will use SSRI, SNRI, and tricyclic antidepressants, and 5-HT receptor modulators, and monoamine oxidase inhibitors. So for the record, I would like to also mention the drug here, like from SSRI example, citalopram, its dose is from 20 to 60 mg, and citalopram, its dose is 30 to 60 mg per day. Fluvoxetine, its dose is 20 to 60 mg per day, and fluvoxamine, its dose is 100 to 300 mg per day, and paroxetine, its dose is again 20 to 60 mg per day, and sertraline 50 to 200 mg per day. This is the example of selective serotonin reuptake inhibitor class. Similarly, next class is that belongs to the antidepressant is the serotonin epinephrine reuptake inhibitors. Out of its drug example is venlafaxine. It's actually 75 to 375 mg per day. As you know, it causes hypertension as well as this venlafaxine. Its doses from 50 to 200 mg per day, and duloxetine, its doses 40 to 120 mg per day, and milanciprone, milen, mila, mi, milna, milnacipram, sorry for the delay. Milnacipram is an example, also example of SNRI. Its dose is 100 to 200 mg per day. Similarly, there is third class tricyclic antidepressant. I have already told you about this. And next is the 5-HT receptor modulator. Its example is the nifazodone and trazodone. Nifazodone dose is 300 to 500 mg per day, and trazodone is 150 to 300 mg per day. And lastly, there is a class known as monoaminoxidase inhibitor, and its example is the phenelzine. Its dose is from 45 to 90 mg per day, and isocarboxazide, its dose is 30 to 60 mg per day, and selaginine, its dose is 20 to 50 mg per day, and phenylcypramine, its dose is 30 to 60 mg per day. So these are the drug classes like SSRI, SNRI, monoaminoxidase inhibitor, tricyclic antidepressants, and 5-HT receptor modulator. These are the drugs which is classes and drugs which is used for the management of antidepressant. This was about point number 11. Point number 12 is about the hypertensive crisis. Like if a patient is being recommended with amphetamine and phenylephrine, ephedrine plus monoaminoxidase inhibitor, he can in this combination can lead patient toward the hypertensive crisis. If and side by side, if you add a tyramine containing food, then patient is in a very serious condition in that way. So just for your reminder, hypertensive crisis is actually crisis is hypertension where blood pressure raises as a dangerous level. For example, it can even reach from 180 to 120 mmHg. So this is a very serious condition. Even death can occur in that. Point number 13 is about to amitriptyline for the treatment of depression and anxiety. It's just just a reminder, like it's amitriptyline is an example of tricyclic antidepressant. It is used for the treatment of depression and anxiety. Point number 14 is about the use of amitriptyline. Again, it's used for the deep vascular pain and post-operative neuralgia, in which persistent pain happens due to traumatic nerve injury during the surgery. So it is also used for that. Side by side, tricyclic person is this is the about the point number 14, and it's used for the depression, deep vascular pain, and post-operative neuralgia. Point number 15 is about some example of the tricyclic antidepressant which we have already discussed here. Uh, this is here they just mentioned one thing more, that is just these all tricyclic antidepressant are used for normal and depressed mood per person. So it's not something that is so technical. Point number next point is about the tricyclic antidepressants and its implication. Why again and again we are telling you this drug? Because this drug is also have a anticholinergic and alpha blocker as well as antihistaminergic side effect. At the same time, it is very useful drug. So that's why it is being discussed more here. Tricyclic antidepressants used basically for chronic severe pain, migraine and chronic and daily muscle contraction, chronic and daily muscle contraction and headache and rheumatoid disease and atypical facial pain, as well as post-hepatic neuralgia and diabetic and other peripheral nephropathic pains. These are some implication of tricyclic antidepressants. So point number 16 is about the monoaminoxidase inhibitor plus tyramine combination. It's again, as I told you, that it causes hypertensive crisis, headache, and sometimes death, and due to intracranial bleeding. As I told you, it can increase in hypertensive crisis. Blood pressure raises at very dangerous level, like 180 to 120 mmHg. So this situation can be very serious. Point number 17 is about the paroxetine. Its dose is 20 to 60 mg and is used for. It is not never use this paroxetine. Example from the class of SSRI. Don't use paroxetine for the treatment of bipolar disorder. As I told you that it is not one of our treatment plan among our treatment plan of bipolar disorder. Point number 18 is about the phenylcypramine. Its dose is 30 to 60 mg. It's actually a irreversible non-selective monoaminoxidase inhibitor. This is a technical point. Point number 19 is about the side effect of paroxetine. It's about it causes gynecomastia as well as sexual dysfunctioning. So point number 20 is about the vilnafexine. As we already discussed here, it's a reminder that it causes hypertension. Point number 22 is about the monoaminoxidase inhibitor. Its example like microbemide. Microbemide is also one of the example of monoaminoxidase inhibitor. So other than phenylcypramine as well as selaginine as well as you can say prazinil and isocarboxazide, this miclobimidine is a miclobimidine, sorry, Miclobimidine is also example of monoamine oxidase inhibitor. 23 is about the imipramine and fluvoxetine. Its dose is about 20 to 60 mg. Fluvoxetine and imipramine is, I think, so you know it's very well. It's belong to class of tricyclic antidepressant. Its dose is from 150 to 300 mg. So it is actually used for nocturnal enuresis. It is basically because of the blockage of and because of its anticholinergic side effect, and which is also used as an therapeutic implication, that is in nocturnal enuresis. Question number 24 is sorry. Point number 24 is about the oral anticoagulant increase the action of imipramine. So don't use oral anticoagulant like direct oral anticoagulant and any other oral anticoagulant with the imipramine, because it increases the action of imipramine, and imipramine, you know, it's tricyclic antidepressants, and excessive use can, its higher action can be problematic for the patient. Next point, that is the our second last point, is about the trazodone plus MOA combination. It actually causes serotonin syndrome. Trazodone is a 5-HT receptor modulator, and side by side, you know, MOI. There are several drugs like selagiline, as trenylcypramine, as well as phenelzine, as well as isocarboxazide. If you use with that trazodone, it may cause serotonin syndrome. So next is about the hypertensive crisis, and here if you use monoamine oxidase inhibitor with the levodopa, it will cause hypertensive crisis. So you have to avoid this combination side by side other combination of tyramine and other, you can say ephedrine side by side CNS stimulants. So point number, that is the last thing, that is the methylphenidate plus monoamine oxidase combination is actually potential CNS stimulant. So potential CNS stimulant. So don't use methylphenidate with the monoamine oxidase because it's a potential CNS stimulant and it's not a suitable combination. So avoid from the hypertensive crisis, serotonin syndrome, as well as potential CNS stimulation, because there is always a specific range and a safe range in which the drugs need to be implicated. So now I would like to share some data from the book, that is the about the, as I told you, in the mechanism of action of these drugs, that mostly tricyclic antidepressant blocks muscarinic receptor, histaminergic receptor, as well as alpha 1 blocker. So let's see which drug blocks which receptor, so that you can get an idea of their adverse effect, and you can easily plan in your prescription while setting a treatment plan. So this drug amitriptyline, as you know, tricyclic antidepressant, it blocks acetylcholine alpha 1 as well as antihistamine H1 receptors. Similarly, amoxapine and bupropion, it's amoxapine also belong to tricyclic antidepressant. It also blocks muscarinic alpha 1, and it also blocks muscarinic alpha 1 and antihistamine H1 receptor, as well as there is a citalopram don't block any of them, as well as clomipramine blocks all, desmipramine blocks all, tepoxamine it also blocks all, fluvoxetine and fluvoxamine it don't block any of these receptors. Imipramine it also blocks all, and miprotylene it also blocks all, as well as mirtazapine and nifazepine it don't block anything. Mirtazapine just only block H1, so there is a chances of sedation with this drug, as well as nortriptyline blocks all, and paroxetine only block muscarinic receptor. So pro protriptyline blocks all, as well as sertraline blocks all, as well as trazodone it also it don't block muscarinic receptor but blocks to alpha 1 receptor, and can also block, or maybe can't block H1 receptor. There is a possibility of blockage of H1 receptor with this drug. Trimipramine blocks all, and vilnafexine don't block anything, and vortioxetine it don't block anything. So this was just combination, that which drug out of tricyclic antidepressant, SSRI, SNRI, or H2 receptor, 5-HT receptor modulator, or MAOI drugs blocks muscarinic receptor, alpha 1 receptors and histamine receptors. So mostly if you don't, just for a single point of view, majority of our tricyclic antidepressant drug blocks these all, like it blocks alpha 1 receptor as multimuscarinic receptors as well as histamine receptor H1 receptor blockers. So be careful while using a concomitant therapy of tricyclic antidepressant once if a patient is already using muscarinic agonist or adrenergic agonist, or you don't want a histamine blockage, so be careful while using them side by side, tricyclic antidepressant, or you should switch the class so that patient should stay away from any danger. So this was all about our about some extracted point relevant to antidepressants. So next, we will jump towards either to the schizophrenia. I will see which topic we'll choose from the CETA CNS. But this topic is end now, and see you soon in with the next topic. Thank you so much for your listening us, and you please subscribe my channel and